Good evening, everyone. My topic is on tips and tricks in the management of intraductal papillary mucinous neoplasms. As we know, IPMN and mucinous cystic neoplasm together are the two cystic neoplasms which have a tendency to go into adenocarcinoma through its route of first developing a dysplasia. So now what makes IPMN slightly different from MCN? The risk of malignancy in mucinous cystic neoplasm is somewhere between 10 to 15%. Whereas in IPMN it could range anywhere between 33 to 60% depending on the type of IPMN it is. Now the difference, particularly what makes IPMN unique, is the fact that field cancerization is something that's exclusive to IPMN and one could have skip lesions as well. And the concept of actually wait and watch, surveillance which is there, is not really true in mucinous cystic neoplasms because there are not enough predictors for malignancy. Whereas the same would be possible in a subset of IPMNs, particularly the branch duct IPMN. So my talk will predominantly cover these two areas. This is what one needs to understand. How do we navigate through skip lesions when we do plan an operation, and how do we plan surveillance in patients that we choose to follow up. IPMN makes up about 1% of pancreatic neoplasms and about 35% of cystic neoplasms. Interestingly, it can be associated with other cancers like colorectal cancers and sometimes even urogenital cancers. The subtypes, like we know, is the main duct IPMN or the branch duct IPMN when it just involves the main pancreatic duct exclusively, or it's a mixed duct IPMN when it combines the main duct along with side branches as well. But the main duct IPMN by itself is again divided into diffuse and segmental depending on the extent of involvement of the main duct. Now this is a picture where on the top left you can actually see a grossly dilated main pancreatic duct, and apart from the T2 bright dilated duct you can actually see some T2 dark areas which are also shown on the transverse imaging, which actually shows the mural nodules. And the third image is one where there's a branch duct IPMN where you can see a normal looking main pancreatic duct. Now histopathologically there are four types: the gastric, intestinal, pancreatobiliary and the oncocytic. The intestinal and the pancreatobiliary being the two ones which are capable of developing into malignancies. The intestinal type develops into a colloid carcinoma and the pancreatobiliary develops into a tubular adenocarcinoma. Now coming to the presentations, most times these IPMNs are asymptomatic. Jaundice and acute pancreatitis will continue to remain the two most common symptoms. What has been interesting is all those patients who've actually had acute pancreatitis have had high-grade dysplasia. Most of the times it is associated with high-grade dysplasia in IPMN, and also they have found a correlation with the intestinal subtype, probably because of the thick mucin that is associated in this subtype. Now this is actually a study which looked at all the people who presented with acute pancreatitis, and the only thing that came out to be significant was that these patients presented with high-grade dysplasia. Interestingly, acute pancreatitis was not so much associated with invasive malignancy, but it was associated with high-grade dysplasia. Also, when they looked at the sum total of the high-risk stigmata and worrisome features in patients with branch duct IPMN who were on surveillance, anybody who presented with acute pancreatitis had a more sum total of high-risk stigmata and worrisome features. Now, next coming to the concept of field cancerization and skip lesions, which is the most important challenge when we decide to operate on an IPMN. So the total incidence ranges somewhere between 15 to 20% of the times there can be skip lesions. Frozen section analysis and intraoperative pancreatoscopy remain the two important tools which will help us navigate this. Together, frozen section and pancreatoscopy will actually upstage the extent of resection in about 30% of the patients, and this will help us achieve R0 resection in 97%. Together they come up to a sensitivity of 86% and a specificity of 92%, and the concordance between frozen section and the final histopathology is also somewhere between 90 to 95%. So what do we look for in a frozen section? There are four different histopathological reports that we could see when we do send frozen section for IPMN. When it's a low grade dysplasia or an intermediate grade dysplasia, it does not need any revision of margin, as opposed to having a high-grade dysplasia or invasive carcinoma where definitely the margin needs to be revised. Now this is a case on the left where we had to do a Whipple for a patient with IPMN who presented with jaundice, and so we decided to do a Whipple pancreatic duodenectomy, a very dilated duct in the remnant pancreas. And the picture on the right is a mixed duct IPMN predominantly involving the body and tail, and we can see the side branches also dilated here, and patient underwent a distal pancreatectomy. Now this is a video of the intraoperative pancreatoscopy in the patient. So who underwent the Whipple. This is the remnant pancreas. So there was a time when endoscopists would do peroral endoscopy and try to enter and actually assess this preoperatively, but the incidence of pancreatitis seemed really high. Currently, this is far more easier for us to do in theatre and actually assess, and there are reports of combining narrowband imaging as well to see altered mucosal pattern to assess if there are any suspicious areas which can be targeted, or if you can just revise if it is very close to your resection margin, again revise and send for some more frozen section. So once we actually finish the operation, suppose we do a Whipple pancreatic duodenectomy or a distal pancreatectomy, obviously these patients are going to remain under surveillance. So what are we looking for in surveillance? It's interesting that patients with IPMN not just have a risk of developing malignancy in the IPMN itself, but they could also have concomitant adenocarcinomas which are non-IPMN derived. In the rest of the pancreas, even if it has not got an IPMN, they actually have a risk of developing a malignancy there. So what happens to the pancreatic duct post resection? The natural history of what happens. About 1/3 of the patients will have a pancreatic duct that dilates over a period of 5 years. But the actual incidence of IPMN developing in this is only about 15 to 20%. There are other explanations for the pancreatic duct getting dilated, like aging, anastomotic stricture, maybe another attack of pancreatitis, or just a passive dilatation after an operation. Now this was a study which actually looked at all those patients who had operations for non-invasive IPMN and what happened to the pancreatic duct. About 27% of the patients had a pancreatic duct that got dilated over a period of 4.5 years. About 72 patients were suspected to be having a remnant IPMN. 70 out of the 72 times it was because of the pancreatic duct diameter. Only 16 of them underwent a completion pancreatectomy. Only 4 out of these 16 had invasive carcinoma. Interestingly, 3 out of these 4 patients had high-grade dysplasia and 1 had a low-grade dysplasia during the original operation. So multivariate analysis from this study showed that the increasing age at which the pancreatic duodenectomy was done or the longer duration of survival were predictors of the pancreatic duct becoming dilated. But none of this seemed to be important in predicting whether there was an invasive component in the remnant IPMN, which means though we are actually having this surveillance, we do not have clear indicators as to when we need to intervene after a Whipple in case we have to plan a completion pancreatectomy. Now this is an example of one patient that we operated. He was 70 years old in 2015 when we did a Whipple for a main duct IPMN. He's still doing well. He's 80 years now, came for follow-up couple of months back. PD looks maybe slightly prominent or maybe the same, but he's generally doing well and he's not had any problems. Now this is the concomitant adenocarcinoma that I was talking about. So apart from the IPMN itself developing malignancy, there can be adenocarcinoma which develops in the remaining part of the pancreas. The benefit of surveillance remains the fact that even these cancers are picked up much earlier. The comparison in relation to the other sporadic pancreatic adenocarcinomas which develop, these cancers are definitely picked up at a much earlier stage. Stage 1, stage 2 cancers are much more common, and these cancers have a higher rate of R0 resection being achieved, and they also do have a better 5-year and 10-year survival rate. Now then comes how do we continue our surveillance in branch duct IPMN if we so choose to not operate and just keep them on surveillance. So branch duct IPMN most times are less than 15 mm in size, and when they're very small they can actually be challenging even to differentiate from serous cystic neoplasms. So over the last 2 decades, there have been umpteen guidelines, multiple meetings which have tried to give us the recommendations in terms of when to intervene in branch duct IPMN. The latest of these remains the Kyoto guidelines that's come out in 2022. Apart from actually revising the high-risk stigmata and the worrisome features, this guidelines also has put down recommendations about how to keep these patients on surveillance, both the resected patients and the patients that we choose to not resect. They've given some clear recommendations as to how to keep them on surveillance. Now, these are the common things that we keep reading, but the two things that were new in the Kyoto guidelines was the recent worsening of diabetes mellitus over a period of 1 year. However, it does not specifically tell us what a recent worsening means, and the size of the cyst growth rate when it's more than 2.5 mm per year, that turned out to be an important worrisome feature. I will be bringing up this number in a couple of more slides again. Now, this is the recommendation for the Kyoto guideline, which we all know. But what is interesting is this part of the algorithm that I want you to focus on, where they've actually tried to delineate the frequency of surveillance depending on the size of the cyst. So when it's more than 3 centimeter, there's a need to keep it on more frequent surveillance every 6 months, and then it goes on between 2 to 3 mm, and when it's less than 2 mm. Now, it has also put in some recommendations. Particularly interesting in Kyoto guidelines is how they've actually said prophylactic total pancreatectomy without frozen section analysis is not being recommended, and they insist on organ preserving pancreatectomy for non-invasive lesions. And the surveillance protocol after a resection will follow either the pathway of an invasive adenocarcinoma, or it will go back to the surveillance of a branch duct IPMN depending on what the final histopathology is. Now, among the only factors that, modifiable risk factors that seem to be important in somebody who is on surveillance for branch duct IPMN, the only thing that turned out to be significant was cigarette smoking. Now, this is another study which actually just looked at branch duct IPMN patients who are being on surveillance over a period of 10 years. None of them had operations, and the only factors that seem to be significant here were the size at the baseline of diagnosis of the branch duct IPMN and the rate of growth of the cyst. What was interesting in this is that at the 10-year mark, only about 24% of them had worrisome features, but at the end of the follow-up, which was about 17 or 18 years, it rose up to 44%. 1 out of 12 patients actually developed pancreatic malignancy even beyond the 10-year mark, and the risk remains at 9.2 times even beyond the 10-year mark. So does that leave us with the option that we may have to continue surveillance in these patients even after 10 years, or as long as they are fit for an operation? Because the current Kyoto guidelines says that once it is stable for a period of 5 years, it may be okay to stop surveillance. But this was a study which said that the risk continues to remain higher even after 10 years. So where do we draw the balance between adequate surveillance versus missing a malignancy? So this is coming from a meta-analysis which has actually looked at two most important factors, which is the cyst size and the growth rate of the cyst. Both the cyst size of less than 15 mm and a growth rate less than 2.5 mm per year predicted that the risk of worrisome features or high-risk stigmata or the risk of invasive malignancy are considerably lower. In fact, the risk of malignancy is is only around 3% when the cyst is less than 15 mm, and the risk of malignancy is less than 1% when the cyst growth rate is less than 2.5 mm per year. Forest plot favoring this strongly, and this is another trial which has actually come out in 2024 called the Pacific trial. Trial conducted across 8 centers where they looked at patients who were grouped into 4 categories depending upon the combinations of cyst size of 15 mm and the cyst growth rate of 2.5 mm per year. So the highest risk of worrisome features and high-risk stigmata was when the cyst size was more than 15 and growth rate was more than 2.5 mm. And similarly for the malignancy, the risk was highest at 19% when the cyst size was more than 15 mm and a growth rate of more than 2.5 mm. It's actually another online calculator that's just come up which tries to include the patient age as well in this, factoring in the patient's age and the size, and then you put it in and then it tells you how frequently you need to keep them on surveillance. A 75-year-old with a 30 mm cyst may need to be on surveillance every 6 to 12 months, but if it's just a cyst size of 15 mm, then we could do it at 12 to 18 months. Finally, I want to introduce this thought using 2 of interesting cases that we actually saw. This field cancer effect that we know throughout the main pancreatic duct, but does it extend to beyond the pancreatic duct itself? Is it a process involving the entire pancreatobiliary tree? This is a 50-year-old gentleman who came to us in 2016, came with a distal cholangiocarcinoma, image on the left, a large polypoidal lesion in the distal bile duct, a normal-looking pancreas at that time, underwent a Whipple, doing well, a normal CT scan in 2017 on follow-up, maybe slightly prominent NPD, maybe just the post-Whipple appearance. Suddenly in 2018 goes on to develop a lesion in the tail of pancreas, and then looked like an adenocarcinoma, so went on to have a distal pancreatectomy with splenectomy 2 years after the Whipple. The pathology of the Whipple specimen was actually the tubulopapillary neoplasm of the bile duct with an invasive adenocarcinoma, what the pathologist called the ITPN, and what was there in the tail of pancreas was actually an IPMN or the pancreatobiliary type. So is there actually a field cancer that extends between the pancreatic duct along the bile duct? We don't know. He's doing well, 2024, recurrence free. That's the last he came for follow-up. Another lady back in 2010 had a large polypoidal mass in the gallbladder, went on to have a radical cholecystectomy, completely well on regular follow-up, almost regular scans.
Can you sum up, please?
Yeah. So this is a lady who subsequently went on to have a large lesion in the body of pancreas with a main duct IPMN, had a total pancreatectomy. So the first biopsy was an adenocarcinoma in what was previously called an adenomatous tumor, but currently we call this an ICPN, and this in the total pancreatectomy was an IPMN. She is recurrence free in 2025 for both the malignancies. To summarize, IPMN can be diagnosed only if there is a strong suspicion for a prominent main pancreatic duct whenever there is not enough explanation for an obstruction. Frozen section and pancreatoscopy are the key. Surveillance in branch duct IPMN needs to be a tight balance between unnecessarily prolonging the surveillance versus missing a malignancy there. The future probably is in understanding if the field cancer effect extends to beyond the pancreatic duct as well. Thank you.
Thank you, ma'am.
So when you are happy to operate surgery for IPMN without sending the patient for a EUS assessment?
So the EUS assessment for IPMN is in main duct IPMN, when radiologically it is very classical or it's a mixed duct IPMN, there's no rule, because whether there is an invasive component or not, the operation is definitely needed. So the role for EUS and IPMN would probably come only in order to monitor for these high risk stigmata. If you're looking for mural nodules, if we do want to see if it has actually become a malignancy in a branch duct IPMN which is on surveillance. But in main duct IPMN or a mixed duct IPMN, we really don't need an EUS.